Altered physiology, mechanisms of disease 2, alterations of the cardiovascular system with a focus on atrial fibrillation. Here in episode 5, we will focus on risk factor modification, continuing on from episode 4, where we highlighted a number of different modifiable risk factors that may be associated with a reduced AF risk and improved outcomes following an AF diagnosis. So let's start off by looking at risk factor modification. These particular figures have been highlighted in the preceding lecture episodes, but really document some of the major risk factors that may increase AF development, progression, and risk for comorbid states. Let's have a look specifically at blood pressure. Previous studies have identified high blood pressure as being one risk factor for AF. In particular, if you're looking at this particular chart, what we can see here is that with increasing blood pressure, there is an increased risk of AF, where 1.0 would represent normal risk and anything above that would represent an increased risk. Now, if we're looking specifically at systolic blood pressures, a normal systolic blood pressure is defined as 120/80. Therefore, we can suggest that a normal blood pressure does not on its own increase one's risk for the development of atrial fibrillation. However, if we look at the pre-hypertensive categories where an individual has a systolic blood pressure of 120/129 or 130/139, you can see an incremental increase in the relative risk. As opposed to 1, individuals now have a relative risk of 1.18 or 1.43. Now, if we jump to individuals who are hypertensive, hypertension being defined as a blood pressure of 140/90. If we look specifically at their systolic blood pressure, ranging between 140 and 159 or over 160, once again, you can see the relative risk increases, such that individuals may actually double their risk for the development of atrial fibrillation simply based on having a high blood pressure. The schematic diagram at the bottom of the screen once again reiterates the multifactorial disease nature of atrial fibrillation. Hypertension is just one factor. Let's take a look now, though, at another risk factor and how modifying weight may impact atrial fibrillation risk over time. What you can see from the legacy cohort study is that with incremental weight loss, individuals are less likely to have atrial fibrillation. In particular, freedom from atrial fibrillation and or atrial fibrillation symptoms was highest among those individuals who had a weight loss of equal to or greater than 10%. This is shown on the graph by the red line. Individuals who had a more modest weight loss still had some benefit in freedom from atrial fibrillation development and or symptoms. In fact, individuals who had a weight loss of 3 to 9% still had a significant risk reduction compared to those individuals who had either little or no change in their weight or even an increase in their weight, as illustrated by the dark blue line, thereby suggesting that changes in one's weight or their level of obesity may once again impact risk for atrial fibrillation development and outcomes. Now, when you go to the guidelines, essentially, there is some evidence to suggest that targeting modifiable risk factors and conditions associated with atrial fibrillation should be applied to prevent further development, progression, or reoccurrence of atrial tachycardia or atrial arrhythmias, and thereby decreasing the burden of atrial fibrillation related symptoms. Now, atrial fibrillation is also associated with a risk of stroke, and this was highlighted in our lecture earlier on. To understand very briefly the underlying mechanism, essentially in the case of an ischemic stroke, it can manifest from atrial fibrillation because of the abnormal atrial beating. And so when you have those electrical signals misfiring and the atrial contraction being rather inefficient, blood can start to pool in the atria, and that is when blood clots can form. When those blood clots travel through the circulation, they can move towards the brain, and that will manifest itself as a stroke, resulting in a very sudden loss of blood flow to the brain and the presence of an ischemic stroke. Notably, Canadian data from the Heart and Stroke Foundation has documented that approximately 15% of strokes are due to atrial fibrillation. The concern here is that while some individuals are aware of their atrial fibrillation diagnosis, others go undetected as they are asymptomatic, thereby placing individuals once again at an increased risk of stroke. Now, looking at how exactly we can manage AF. First and foremost, a confirmation of an AF diagnosis must occur with a 12-lead ECG or even a single lead ECG that lasts for greater than 30 seconds, characterizing and showing a pattern of atrial fibrillation. The second step is really to characterize AF using this 4S scheme. And so what you can see here is really to evaluate stroke risk, symptom severity, the severity of the AF burden, so how long, for example, an AF episode lasts and whether it terminates by itself, and then understanding the severity of substrates, so factors that may increase one's AF risk, such as age or other comorbidities or the presence of atrial enlargement and fibrosis. Lastly, in terms of AF management, there are various treatment options. Anticoagulation, for example, may be used to avoid stroke in those patients who are deemed to be high risk. There is a CHADS score that can be used to classify one's stroke risk and whether anticoagulation therapy may be indicated. A second part to AF treatment is in terms of symptom control. Being able to assess the symptoms, the quality of life, and the patient's preference for medical intervention will be important. Ideally, one will optimize rate control and consider a rhythm control strategy, such as ablation. And lastly, in terms of treatment, looking at risk factor management, trying to modify risk factors, thinking about lifestyle changes such as obesity reduction, changes in blood pressure, regular exercise. All of these factors can be considered in the management of AF. And that concludes this lecture episode.